Hi, I'm Tammy Potter, and welcome to the Pregnancy Process Podcast, a show designed to help you navigate the hugely transformative journey to motherhood, where you'll hear the unique experience of experts in this area and the incredible stories of women sharing their conception, pregnancy, and postnatal journeys so that you can have a healthier, more informed pregnancy. In today's episode, I talk to renowned fertility specialist, obstetrician and gynecologist, Dr. Violet Kieu. Dr. Kieu holds a prestigious subspecialty qualification in reproductive endocrinology and infertility, a credential achieved by fewer than 80 specialists across Australia and New Zealand. As clinical director at Melbourne IVF, she's a passionate educator for both women's and men's health and fertility. In this thought-provoking episode, Dr. Kieu helps unravel the complex relationship between Polycystic Ovary Syndrome and fertility, offering invaluable insights into cutting-edge treatments and lifestyle modifications proven to optimize fertility and manage PCOS symptoms. So if you or someone you know is struggling with fertility due to polycystic ovary syndrome, then this episode is absolutely for you. So get ready to be equipped with the vital guidance and support necessary to help navigate a fertility journey with the unique challenges of PCOS. Dr. Kieu, thank you so much for your time today. It's fantastic to have you here with us.
Oh, wonderful. Thanks so much, Tammy. Glad to be back.
I know after our last conversation around endometriosis, and for the audience, if you haven't watched that podcast, absolutely head over to that episode after this one because there's so much incredible information in there. And I'm so excited for this podcast around PCOS, especially because I have a new client that's recently joined my face-to-face coaching business, and she's actually been through this journey. So she's been diagnosed with PCOS. She's been through the IVF journey. She had 4 failed implantations and now she's pregnant. So she's 12
that's
weeks
wonderful.
pregnant. I know. And so I feel like this episode is going to hold a little bit more of a special meaning for me, knowing that I'm now caring for someone that's going through this process, and she's at higher risk for things like preeclampsia, gestational diabetes. So I feel like I'm going to be learning a lot about her journey at the same time as talking to you around PCOS. So I think if it's okay with you, can we start with the basics around PCOS? Like, what is PCOS, and are there certain factors a woman should look out for that might indicate that she has PCOS?
Yeah, wonderful. I'll just like to start by saying I think that is absolutely amazing that one, PCOS, polycystic ovarian syndrome, is common. It's the most common metabolic condition affecting women, and some estimates up to 20% of women. The different studies go from 2 to 20%, but that's common in a reproductive population. What heartens me is not only that you have a client who has PCOS, but it's been diagnosed, it's been managed, and you're in this space so aware of some of the pregnancy complications that she or other women with PCOS may be at risk of. So taking a step back, but we will talk about IVF and pregnancy and PCOS and other fertility modalities. But from the very basics, we don't know exactly what causes it, but we do have different contributing factors that we talk about. And these include genetics. So if you have a family history and your mum or first degree relatives who have it, we think about, is it environmental, such as high levels of testosterone for whatever reason that you are exposed to in utero. So when you're a fetus or a baby inside your mother's tummy. And then there are other general environmental factors that there is more research being done around, and these can include endocrine disrupting chemicals. So different factors, but then how it manifests or presents itself is different for everyone. And that's because it's a syndrome. So there are different components of it, and some might have one part and someone might have another. So we have classically something called the Rotterdam criteria. And once a general practitioner or a specialist gynecologist or an endocrinologist has excluded other conditions, then you have 2 out of 3 of the Rotterdam criteria to be diagnosed with PCOS. And so those 3 things are irregular periods. So we say, on average, a regular period cycle is 28 days, and we allow a week either way. So if your periods cycles occur greater than 35 days at a time, that's one factor. Another factor are signs of testosterone excess, and that can either be clinical, so something that you see, notice, or feel, or biochemical, something that we measure in blood tests. The ones that we can see, people might have hirsutism. So of course, across all different ethnicities and racial groups, different hair patterns. But for you or your family, if you have more male pattern hair, so that's chin, lip, chest, back, etc., and you're concerned, please go again, GP, gynecologist, endocrinologist, to see if that's within normal for you or not. And there are other things such as severe acne. So again, that's really bad acne on those body parts I've mentioned that are testosterone dependent, and also male pattern hair loss. So that can be something that you notice predominantly, say, on your head, for example. So that's what you might experience, or it might be measured in a blood test. And the third factor are ultrasound factors. Now, this is actually more common. It has been reported in some studies that potentially up to 1 in 4. So perhaps women might have this PCOM, polycystic ovarian morphology, and morphology meaning shape, and different criteria, but one of them being more than 20 follicles in one ovary. So again, just from the basics, an egg, a single egg is a single cell that can become a baby, and it lives inside a follicle. And we can't see the egg, too tiny, but we can see the follicle that supports it. Think of it like a soft eggshell. So if we can see so many of these, we think, aha, is this in isolation or is it part of the syndrome? Yeah, so that's how one might diagnose. Any specific thoughts from here? Or I can go on.
I would actually really like to go into those individual factors that you were talking about. So
Sure.
understanding that the exact cause of PCOS is unknown, and that it's a combination of the genetic, epigenetic, and environmental factors all play a role. Can we discuss those individual factors and how they work together to place women in a position of being diagnosed with PCOS? So if we can go further into the genetic, epigenetic, and I'm especially interested in environmental.
So all that's emerging. So I think one should take it broadly that genes, we are half mum, half dad. And even within a woman, let's say, our eggs are a mix up of our DNA. So therefore, we have diverse children, or we have the potential to have diversity in offspring. And as such, we think that there might be multi-gene factors, so interplay. So there isn't a gene test for PCOS at this stage. So familial, so that's a risk within families. In terms of epigenetics, so just so to clarify, our genetic material is in chromosomes, which are like textbooks, and they just look like figure X's. And we have a usual number is 46. And they are textbooks because under certain conditions, these cell will replicate and you'll open the book of these chromosomes. And in terms of a sentence, you have genes, and genes transcribe proteins, transcribe function. Now, what alerts the chromosome or the gene to activate? Markers. And these are, again, different other proteins that work around the gene to make it work. And that's what epigenetics is, how we might activate or not activate different genes. So yes, it is an emerging field, epigenetics. It is an emerging field, environmental disrupting compounds. And there are so many that it may be in the media, and without going into granular detail, some of these environmental disrupting compounds are very prevalent, and thus maybe on our part, there are simple day-to-day things that we can do: wash our fruit, take off our shoes before we come in the house, not touch too much our receipts that have been heat printed because that black material may be an endocrine disruptor if you touch it. Not microwaving our food in plastics, putting it into your ceramic or your glass container. So these are the life day-to-day things I think that one should be aware of.
Are there any other environmental day-to-day things? Because those were some really great tips there, and I think there was some really good takeaways. But can we maybe talk a little bit why you shouldn't be microwaving your food in plastic, why you should be taking your shoes off before you come inside, or not walking around inside, not touching receipts? There's obviously chemicals, and you're talking about high testosterone levels here, and that you've already mentioned that high testosterone levels in vitro is part of this, the male hair pattern, hair loss, acne. There's obviously high testosterone involved in PCOS. What does that have to do with the environmental factors that we're constantly being exposed to?
So I'm going to bring it back to PCOS. You have asked about what might be the cause of it. So I've gone through the broad categories: genetic, environmental, in utero, and also external environment. It is not a direct line. I again just want to clarify for listeners that these are what we think of as contributing factors. We are not saying, or I'm not saying, that there's a direct line from one to the other. These are just in the literature, things that people have looked at to try and help us understand PCOS. In terms of the day-to-day for a PCOS woman, what's important to know is that there are some other things that are occurring. So the brain controls our ovulation. And that's why one of the diagnostic criteria is that longer period cycle. So in the perfect cycling woman, the brain cleverly releases follicle stimulating hormone, act on the ovaries to grow a follicle one at a time per month to ovulate, to have a chance of pregnancy or not. And the FSH helps a small follicle grow, and then the LH, or the luteinizing hormone, helps the follicle have the ovulation. Now, we do know in PCOS there are a few hormones that are changed, and the pattern can be actually a higher ratio of the LH compared to the FSH, and thus potentially your little eggs are in an almost arrested state. They don't progress through the process of maturation at the same rate as a regular cycle, and thus that's why the cycle can be delayed, and also why we think we can see the little follicles as arrested follicles in the ovary, and that's why we get this number of, say, 20 per ovary, or at least one ovary, to have that diagnostic criteria for the morphology and or later for the syndrome if there are other factors. It's also important to note that whilst it's called polycystic ovaries, technically they're not cysts, they are follicles because they contain eggs. So that's important as well. And that's how there's so many different ways, and I mentioned the diagnostic criteria. In summary, the effects of PCOS on a woman can be metabolic. So we'll talk about weight, talk about heart health, talk about obstructive sleep apnea. We can talk about cholesterol, sugars, type 2 diabetes. So that's all your metabolic things that may be associated. We'll talk about your fertility, which is largely your anovulation or not regular ovulation, which may make it harder to fall pregnant. Though reassuringly, many people or many women with PCOS do fall pregnant, but those who have difficulty, we can help. And then the third aspect, which is actually very, very important and has had more emphasis on the more recent International PCOS Guidelines of 2023, has been attention to mental health. We do have to address that. And that can be recognizing that giving all these symptoms, as I mentioned, can impact on a person's anxiety, depression, quality of life, self-image, etc. So that's very important that we involve talking therapies, psychologists, counselors, psychiatrists, need be, as well as our GPs.
Amazing. And everything that you've just ticked off there, I'm like, yes, absolutely. We're going to talk about all of those. So before we get into the metabolic disorders that PCOS is linked to, and then moving on to the fertility and overall health and well-being side of things, Can we talk through the diagnosis process and what that might
Yes.
entail? So say for me, I have noticed a change in my hair pattern, or I'm getting acne and I'm concerned about that. Obviously, my first step would be going to the GP.
Mm,
Then what are the stages from there? What would someone listening to this podcast who might be concerned about these things, what can
mm,
they expect when going through that diagnostic process? Because
yeah,
these things can be scary sometimes. And,
definitely.
I know from my own perspective of being diagnosed with celiac disease, these
Right.
things don't happen overnight. I remember that process was long, and it took months, and there were so many different steps and stages, and I had to do this and that. So, and it can be
Yes.
quite scary when you're dealing with unknown health issues. So if we can
Yes.
talk through that diagnosis process, that would be amazing.
Yeah, brilliant. So, just to couch all that, it's really actually amazing that we're talking about PCOS and last time about endometriosis. So, this is great. Women's health should be on the agenda. And recently, the federal government, as I understand, has announced more funding for Medicare for longer GP consultations for complex women condition such as PCOS and endometriosis and or pelvic pain. So, first, GP, and maybe have a look or to see if a GP who, and part of my understanding of the government's focus on this is also to improve the education for GPs. We all need updating, and as I mentioned, guidelines, etc. So to go to a GP with an interest in women's health, that would be my first recommendation. Okay. So history, exam, investigations, management plan, they are the cornerstones of clinical care. So history would be wide ranging, but you have mentioned male pattern hair loss and acne, for example. So I would say a general history would be presenting complaint, like how long have you noticed this? Where have you noticed this? Has this been a problem? Have you tried things? Have things helped? Have you noticed any difference, for example, during your period cycle and associated with that and your acne, for example? And then a well woman talk would also talk about gynecological health, period health, general medical health, looking at your diet, exercise, and weight. And then also any surgical history, what you do for work or leisure, any medications you take or other things that you may take, including smoking and alcohol. And then focusing again on the two things that you've mentioned, male pattern hair loss and acne, that may include having a look at these areas and a thought process. Is this something that they think fits a pattern of PCOS, or is this something isolated, for example, that they might refer on to a dermatologist? And certainly, I do work with some dermatologists because our combined patients intersect. And then, if a GP, for example, or even a gynecologist, because that's the reference points that I have as a fertility specialist and gynecologist, might be to do investigations if we think PCOS is on the list. So things that we would do include a hormone profile. I've mentioned testosterone. So we'll do testosterone as a blood test. But many of us may do the other sex hormones. So your FSH, your LH, and your estrogen, as I have already mentioned, and progesterone. And that can just help us have a look at if it fits a pattern of PCOS. Also, we would consider the ultrasound, and that's a pelvic ultrasound where a probe usually goes inside to have a look at the ovaries. But of course, if people are not comfortable with that, we could always try transabdominally to have a look at the ovaries and uterus as well. Now, depending on a result and if a clinical diagnosis of PCOS is made, then to address the other metabolic conditions, it would be a discussion about the pros and cons, about testing cholesterol, about testing for diabetes or sugar or insulin resistance. So those are the other, and the lipids as well. So those are the other things that can evolve from making a diagnosis.
So we've got a cluster of risk factors around PCOS from a metabolic perspective. We're talking about things potentially like obesity, we've got insulin resistance, there's systemic low-grade inflammation. And these all do have significant, and I know you haven't mentioned some of these, but these are some things that I do know tie in with that. And these things do have significant impacts on a woman's overall health and well-being.
Mm.
Can we talk about the link between PCOS and metabolic disorders like your insulin resistance, your type 2 diabetes, the low-grade inflammation, potentially obesity?
Yeah, so I'll bring it back to evidence-based guidelines. So the International PCOS guidelines do say there is a link between PCOS, and thus the number one management that we have to emphasize is lifestyle, actually, for PCOS to prevent or decrease the severity of progression to some of these conditions, including cardiac, heart health, obstructive sleep apnea, type 2 diabetes, and there is an association with obesity. So, one of the cornerstones of the recommendations is to, in a respectful manner, address weight. And if weight, for example, and it is a crude measurement, the BMI, you're measuring height and weight, and there are other factors in terms of disposition of fat to lean ratio, etc. But just using in a guideline BMI situation, if you do have an increased BMI more than 25, which puts you in the overweight range, etc., or higher, there are things that we recommend, including moving your body, exercise. So the most baseline recommendation is 150 minutes of moderate exercise per week, which only works out to be only like 30 minutes, 5 days a week, or you can cut it different ways. Of course, it's not just about weight loss, it's about health, and it's about maintaining healthy weight, potentially preventing increased weight gain. So it is absolutely very important in terms of exercise and having education around healthy eating as well in the guidelines. We do not recommend any specific dietary type over another, but of course people are very welcome to work with dietitians, allied health, etc., to have an individualized diet plan that suits them.
So what's causing this link between that? Do we know what's causing the link between these metabolic disorders and PCOS?
Yeah, so it is, as mentioned, whilst so common, it's so complex. And I don't think one person has the exact answer of why PCOS happens and why it's so systemic overall. But we do know that having the insulin resistance does actually have interplay with effects on the follicle stimulating hormone and the luteinizing hormone. So their interplay together can affect our ovulation. And certainly, this is why when we move to different management plans, the things I have mentioned include lifestyle, lifestyle, lifestyle. That is the number 1, 2, and 3, right? But then after that, addressing disease prevention, again, awareness, testing, preventing those long-term heart health issues I've mentioned, but also what treatments we can do now. So really the treatments we have, lifestyle, but also medical, and these can be things such as metformin, which is an insulin sensitizer to help your cells more properly use the insulin and regulate your sugars. And that is somewhat recommended for those with PCOS and that increased BMI over 25. And then if you have irregular periods, then some of the thought processes can be around the pros and cons of trialing the oral contraceptive pill as well. Because specific to PCOS and irregular periods, what is a period? A period is the growth of an egg and then shedding of the lining. Yeah. But if we have our period cycles too far apart and we don't regularly shed our lining, over years, the lining may become irregular and we're at risk of endometrial hyperplasia, which is many, many steps before, but is a precursor to endometrial cancer, right? And thus, using the pill, there are pros and cons to any medication, and thus you'd have to individualize it. But one of the pros of the pill is having a regular menstruation to protect the uterine lining against the development of endometrial hyperplasia and cancer. So that's one consideration. So we've talked about metformin, we talked about the pill, in addition to our lifestyle and diet. And then other targeted management may be specifically if you have hirsutism, which is a fancy or medical word for male pattern hair growth, you might see a dermatologist or other person who might be able to help with, say, laser. But if you have male pattern hair loss or acne, again, a dermatologist has other medications that they can use specific for those. If you have weight issues, part of the guidelines actually do now address, this is, a very topical topic, weight loss medication, okay? Injectable weight loss medication, the GLP-1s, okay? Knowing that our recommendation is, if we are on it for medical reasons, to have contraception as well, because we don't know the long-term effects on the fetus of these newer medications, and really talking to a person about the goals of therapy if we start one of these medications, because there is some thought process that there are some unknown risks or other risks, such as to liver or kidney. So there are some people who it's not suitable for, but you have to seek medical advice. But also, once we stop one of these medications, there may be a period of resumption of weight gain. So really to understand why we're taking a particular medication. And along that track of weight, bariatric surgery is another step on that path. And then, so that's in your non-wanting a baby situation. That's your general day-to-day PCOS management. But then, if you want to talk about fertility, there's a whole other thought process about how we can help with that as well.
Amazing, because you've literally opened the door to my next question. So thank you for that. In terms of fertility, and before we get into this, there's a couple of things that you've mentioned here. Firstly, hallelujah. Finally, in Australia, for people overseas, we are under a Medicare system that supplements, I would say, some of the prices of our medical care here from a government level. Now, things like female health, I truly believe we're not being supported as well as we should be around some of these things. And there's certainly some gaps. And when it comes to the pregnancy journey and the postnatal recovery journey, I know there's been some really significant advocating for changes around pelvic health, pelvic floor health postnatally, which we don't really have here from a physio perspective. So just to hear that there are some changes in that in terms of pelvic pain, endometriosis, PCOS, and finally we're starting to get a little bit more support from a Medicare perspective. I think that's unbelievable. So that was fantastic news. Thank you for sharing that. I did not know about that. So I'm really happy to hear about that. But then in terms of the injectable medication, those risks really are terrifying. The fact that you need to be on a contraception because we just don't know the effects on the fetus if you do fall pregnant. So I think it's so glorified at the moment that I think some of these risks, and I'm really glad that you went through them, because it is quite glorified from a celebrity kind of area. And I think the actual health risks are not being spoken through enough. So I thank you, even just for pointing out that one little thing there in terms of we don't know what the risks are to a fetus. So I think anybody that's considering that road, I think really should look at the risks on that. And that's all I'm going to say on that, because I really want to talk about fertility and the effects of PCOS on fertility and conception chances.
Yeah, excellent. So a few things. With the GLP-1s, it is an emerging space, and it is important, if one does use them, to be aware the aim is not to have a pregnancy, but if it does occur, then we will support you. So to, of course, let us know. In terms of fertility, yes. So 2 key points. 1, not all doom and gloom. People with PCOS have babies. Okay, so that's that. And secondly, people with PCOS can also have infertility unrelated to PCOS. So you can still have tubal factor issues. You can still have, if you're in a heterosexual relationship, male factor issues as well. So we do not just have to look at PCOS, but the whole situation in fertility. But now, moving just to PCOS, the major issue, well, I'd have to say too, the major issue is that anovulation, not having the regular period around 28 days or between 21 to 35 days. Like some people might not have a period for 3 months or 6 months. That's hard to fall pregnant if you don't have a mature egg around. So from the top going through, lifestyle, even 10 to 15% weight loss can help regulate periods. But then once we're actively trying to put you through assisted reproduction. The 3 levels include ovulation induction with tablets, ovulation induction with injectables, and there's sort of brackets, ovarian drilling as another option on level 2. And the third and final option, or I'd say the most high-powered option, as your client ended up using, was IVF. So ovulation induction can be done with different tablets, but the most common that I use and our colleagues that I talk to in Australia would use is letrozole. So that's a tablet that stops the conversion of testosterone into estrogen. Okay, so you only take it for a few days. So if day 1's your first day of your period cycle, then what I do, but other people do different days, from days 3 to day 7, so that's 5 days, 3, 4, 5, 6, 7, take the letrozole. And then your brain is tricked into thinking, oh, there's not a lot of estrogen around. Okay, in a feedback loop, let's increase our own brain follicle stimulating hormone. And that little boost to that follicle stimulating hormone might be enough just to drive the ovary to recruit and mature an egg for conception. It is a prescription-only tablet, so this does require discussions with your gynecologist or fertility specialist. And like any medication, there may be side effects, usually mild, and that might be more tiredness, headache, nausea. And thus I do tell people to take it at nighttime before they go to bed so they can slip off those generalized symptoms. I run ovulation induction cycles monitored. So that is by day 8 or day 10, I'll ask a patient to come in so we can do an ultrasound scan to show if we've responded, if there is a growing follicle actually, but also to count how many follicles have responded. The aim of ovulation induction is 1 big follicle at a time. If we see 2, I will talk to people about the risk or chance of twins, and if they would accept that, and if they don't, not to have sex that month. But if they would, knowing that twins has an increased risk of premature babies, admission to neonatal intensive care, and also for the woman, higher risk of cesarean, blood pressure issues, and diabetes. Once they've been adequately counselled, if they wish to, we can go ahead with 2 follicles, but 3 or more, no, cancelling that cycle. And I may also do a blood test just to double check your estrogen, LH, and progesterone. So that's an ovulation induction cycle. And we can do that for 3 to 6 months or cycles or so. Then if that is not working or they don't respond, then a second line would be ovulation induction, that is growing an egg, with low dose follicle stimulating hormone injections. So it's pretty much exactly the same as that you make in your brain, but it's an injectable that you inject into your belly daily, and it's low dose, and you do need to come in definitely for us to see the response. And it's almost like a switch. Sometimes the low dose, you get no recruitment, then suddenly, boom, you might get over recruitment. So the risk of multiples is higher with low dose follicle stimulating hormone injections, and the risk of cancellation then is also higher. So that's very hard to titrate or to get the perfect dose per person, but it can help. Now, if you're going to do a laparoscopy, that is keyhole surgery for any other reason, it may be an option to do ovarian drilling, just to make 4 small holes, pinpoint holes in the ovary, just to stimulate egg growth, though that is not a common approach these days. I think it's probably more common previously. And overriding all of this, even in the guidelines, it is a discussion, do we need to check the tubes? And there's no hard and fast, and there's no you must do it, but there is something called a tubal flush ultrasound, which I do discuss with my patients, because if we're doing all this effort to grow an egg and time intercourse, or even timing intrauterine insemination, that is putting the sperm inside high in the uterus at the time we think the egg is most likely to ovulate and be ready. If you have your egg and your sperm, you don't have the tube as a road to connect them, then all of this effort, well, so a tubal flush ultrasound is referring you to a radiology place where they might put a teeny tiny tube from below into your uterus, put saline or salty water from below, and then do an ultrasound on top to see if there's fill or spill of the tubes. And that just demonstrates, yep, the salty water can go through the tubal system. But if not, then we might have to think, if you have blocked tubes, well, actually, that is the first indication of what IVF was made for, to bypass a blocked tubal system. That is to take eggs out, mix with sperm, and then put embryos back through the uterus from below. So then that would be the strongest fertility treatment that we would offer in the IVF.
Amazing. And so just to confirm in my own mind here, Is the effect of PCOS on a woman's fertility and conception journey, is the main cause around the cycle and the delayed cycle or irregular cycles? Is this one of the key factors? Are there any other factors that would impact the fertility and conception journey besides from the
Definitely.
cycle?
Yes, it's the high association with weight as well. So we do know that, for example, weight. So in our fat cells, they also are metabolic cells. So they can also add to different hormone loads or actually different types of estrogen. And as an independent risk factor, increased BMI is an independent risk factor for, say, endometrial hyperplasia. So there are different things. So increased weight can also be associated with increased risk of miscarriage, infertility in its own right, as well as pregnancy risks going on. And that's, as I've mentioned, and I think you've mentioned as well, so risks of blood pressure issues, preeclampsia, type 2 diabetes, and for the baby, small babies, big babies, hard to monitor as well. And such, we need to address peri-conception health. And that is, again, addressing all the lifestyle things, your smoking, alcohol, endocrine disrupting chemicals, also getting enough sleep, enough exercise, and also prenatal vitamins. And if you do have an increased BMI, we do actually recommend a higher dose of folate to protect against the risk of spina bifida, which is nerve issues in the growing fetus. So a lot of this is actually making a diagnosis of PCOS ideally early on in someone's life, manage them, but when they wish to attempt a pregnancy, to come back for medical attention and a discussion around this periconception time as well.
So would you recommend lifestyle intervention prior to embarking on a fertility treatment journey?
Whilst I wouldn't say intervention, I think I do hope that one of the key messages is attention to lifestyle if you're diagnosed with PCOS across your lifespan, actually, because that we do know that poor health has mental health, and then mental health can affect physical health. And so these are key factors, again, attention to the way you live your life to prevent disease and to improve the chances of fertility on later in life. Yes.
So when it comes to pregnancy, women with PCOS, as you've literally just mentioned, they do have increased risk of pregnancy complications, gestational diabetes, preeclampsia, sadly miscarriage, preterm birth, babies, big babies, especially if you've got gestational diabetes, there's issues there. What would your recommendations be to help a woman diagnosed with PCOS through her pregnancy journey?
Yeah, I think it's about awareness and communication. So if a diagnosis of PCOS has been made pre-pregnancy, and it depends on the individual in terms of the health services that they may wish to engage with. But some of the things I do for some of my PCOS and increased BMI women is a review with, say, a high risk obstetrician so that they can, again, optimize and go through some of these risk factors. And this may include looking at blood pressure, seeing if someone does need to go on a pregnancy friendly blood pressure medication, because, again, preeclampsia, which is very severe, uncontrolled, and actually quite complex, that risk exists. Also, to have a plan if we have found someone has insulin resistance, we're concerned about the progression of gestational diabetes or type 2 diabetes, pay attention to that as well. I think it's all part and parcel. And if that option is not available or not uptaking, to have the periconception obstetrician review, certainly once you are pregnant and in a health service, in a wonderful public hospitals, to inform your midwives, the obstetricians that are caring for you, because they may or may not be teams based, just to have it in conversations that people are aware on the same page, that this is your understanding of your condition, and just to have that communication. And I think having conversations is number one.
So in terms of the effects of exercise during pregnancy, because I really know when I look at the effect of exercise on potential gestational diabetes risks, preeclampsia, all of these things that we're discussing that are surrounding PCOS, I know that there's a really positive effect of exercise on all of these things. So can we talk from like a medical perspective around the effect of exercise during pregnancy on things like gestational diabetes and preeclampsia?
Well, I would say from the guidelines, I've talked about the 150 minutes of moderate exercise, and they also do recommend on 2 non-consecutive, so 2 different days of the week, some sort of strength-based training. And instead of, or another way to cut the recommendations, might be even a minimum of 75 minutes per week of high intensity. And so, in summary, 150 to 300 minutes of moderate activity, or 75 up to 150 of high intensity. I would say that that's where I would generally discuss with a patient, and then it would invite a patient to tell me what they do and to see if that fits within. If they don't do anything, well, time to start doing something. But if they are, for example, performing at a higher level than that, then to have just an open discussion about what their thoughts are, what they've read, and potentially what they've talked about with people such as yourself, Tammy, who are very involved in that exercise health space in pregnancy.
And in terms of the management of PCOS, it's ongoing. It requires,
Yes.
as we've discussed a lot through this podcast, it requires significant lifestyle modifications, medications. In some cases, there's surgeries involved. And anyone facing such major change really requires a support system. So, for someone diagnosed with PCOS, what recommendations do you have around creating a support network to help you cope with the mental, emotional, and physical aspects of this, let's call it a disorder?
Yeah. I'm so glad you asked. That's wonderful. That's the heart of it. How do we help people live their lives with PCOS? So, number one, your GP. We've got now more education for GPs, guidelines, and also access to, for example, mental health plans that they can help with a psychologist to go through some of the stresses associated with this condition, the metabolic, mental health, and fertility issues. Secondly, there are government supported bodies such as Jean Hales, which is a women's health platform on the internet, and they have been supported by the government, or recommended rather by the government, to produce quality educational materials. So these are accredited materials. And not only that, they have clinics where people can come in and see a specialist women's health GP. So that is also another resource. And they support things such as Women's Health Week, which is in September. Further to that, I would say reach out to your own personal supports. So that's friends, families, colleagues, and see if they have any other groups that might be helpful for you in your region.
Because that's a very significant health diagnosis. You can't go through these on your own. You really do need a support around this. And even just having, like I said, conversations like these are so important, and just getting this information and education out there, because someone listening may not have PCOS themselves, but they may know someone that's got it, or they may listen to this and think of someone in their sphere of influence and think, actually, maybe this needs to be something that they need to listen to as well. And it could just open up that path of discovery for them. And I think, have you got any other things that you feel like we haven't covered? Because I feel like we've covered so much. Is there anything else that you'd like to talk to in regards to PCOS and fertility, pregnancy, conception, health and well-being
Yeah.
before we wrap up?
Yeah, well, I'd just like to emphasize what you said, because I think empathy and seeing how someone else might have to live with a chronic disease is so vital. And we do know that word of mouth is very important in people's lives and recommendations. So if someone does listen to a podcast, does see a health sheet from your fertility.com.au, which is another Australian government associated website, or from Jean Hales, etc. It just is advocacy that these issues are important and affect people's lives. So all I would add to that is, if you do wish to discuss more, myself, I am a fertility specialist. I'm a clinical director at Melbourne IVF. I have my own website and do some education on a smaller level if you wanted to have a look at those things. But I think, number one, education, and then two, seeking help, and three, advocacy once you've got the help that you need, help others.
That's amazing. And one last question. If there's something that you wish all women knew before having a baby, falling pregnant, what would that be?
It's a journey, and everyone's journey is different. So to really be the best that you can be in your journey, knowing that it may very well be different to someone else. And sometimes comparisons aren't helpful. And your journey can be beautiful no matter what the outcome is.
That's such a beautiful way of looking at it, because it is so true. No one path is identical when it comes to this journey. And I truly believe that every single woman, irrespective of whether they have children or not, they've all got a story when it comes to this aspect of their life. And I think just having care and compassion around every woman's decisions, every woman's journey, and its uniqueness, I think is so important. So thank you so much for that. And thank you so much for your time today. It has been so wonderful talking to you and having you share from your absolute wealth of knowledge. I feel really grateful to be able to have you on the podcast. So thank you so much for your time.
Oh, my absolute pleasure. And thank you, Tammy, for having me on. And thank you for listeners for listening.
And if you're hearing this message, I want to say a huge thank you, because it means that you've listened to this entire episode. Of course, if you have any questions about the things that we covered in this episode, or want to know more about me or my other projects, you can find me on YouTube and Instagram at The Pregnancy Process. For those currently in their conception or pregnancy journey, you can apply to join my complimentary but private community, the Preggy Training Crew. And you'll find my community application and social media links in the episode description. And of course, if you enjoyed this episode, I absolutely encourage you to share it with other women just like you. And I look forward to seeing you in the next episode.